Cushing's that needs mentioning, and that's hyperandrogenism. Turns out that ACTH doesn't just stimulate the zona fasciculata of the adrenal to produce cortisol. It also likes to stimulate the zona reticularis. This activates androgen production, which in women can manifest as hirsutism, acne, and virilization. These effects are particularly pronounced in women because the adrenal glands are their primary site of androgen production, while men have testes to produce most of their androgens. Okay, on to our next case of endogenous Cushing syndrome. This time, we've got a tumor right in the adrenal gland itself, symbolized here by the lamp sticking out of the front of that adrenal cap. This can either be an adenoma or carcinoma. And in most cases, these masses do not produce symptomatic adrenal disease. In some cases, however, these masses start to secrete cortisol autonomously. And that's why we're turning up that cortisol moon phase light. This can lead to a so-called ACTH-independent Cushing syndrome. Independent meaning that no outside stimulation is needed. In fact, due to all the cortisol getting pumped out of the tumor, expect the usual negative feedback mechanisms to do their thing, resulting in decreased levels of ACTH. This also means there will be no signs of hyperpigmentation. No ACTH means no MSH. Actually, I think there's something in there.
Oh, sweet Mrs. Buttersworth.
Okay. It's just Mittens. I forgot he came along. Without ACTH stimulation, the adrenal tissue around the tumor on the affected side, as well as the entire contralateral adrenal gland, get all hypofunctional and, over time, atrophy. We've illustrated this characteristic appearance in bilateral adrenal hats. That lamp represents the tumor, remember? And notice that the tissue around the tumor on the ipsilateral side, as well as the entire contralateral adrenal cap, are all shriveled and sickly looking. This atrophy is in the zona fasciculata only, by the way, as that outer aldosterone-producing granulosa layer relies, instead, on the renin-angiotensin cascade for stimulation. The last cause of endogenous Cushing syndrome to discuss is ectopic ACTH syndrome, in which a tumor is secreting not cortisol, but ACTH. To evoke an image of a tumor outside the adrenals, one of the team members has taken the rover out for a joyride away from the lunar base. Notice, too, the uncanny resemblance to our recurring cancer crab symbol. The most common sources of ectopic ACTH production are from tumors of the lung, especially small cell lung cancer and bronchial carcinoid tumors. Other sources include non-lung carcinoid tumors, medullary thyroid carcinoma, and pheochromocytoma. In the setting of ectopic Cushing syndrome, patients will have high ACTH levels, which drives chronic cortisol secretion from the adrenals. And remember, elevated ACTH levels go hand in hand with elevated MSH levels, leading to hyperpigmentation, of course. And finally, all that ACTH being secreted from the tumor chronically stimulates the adrenals, which, over time, leads to bilateral adrenal hyperplasia, just like we saw with Cushing's disease, when the ACTH was coming from the pituitary. All right, one disease, so many causes. Where to begin? First, keep an eye out for symptoms like truncal obesity, proximal muscle wasting, moon phases, and consequences of hypercortisolism like diabetes, hypertension, and osteoporosis. That's one small step to notice these signs, however. Next, we'll take the giant leap into diagnostic testing. Okay, a little forced, but I had to fit it in somewhere. Serum cortisol levels fluctuate throughout the day, so two ways to check for hypercortisolism are a 24-hour urine-free cortisol test and a late-night salivary cortisol test. Late night, because your cortisol levels are not supposed to be that high right before bed. Okay, so your patient comes back having lots of cortisol. How about that ACTH I keep hearing so much about? Well, let's take a look. ACTH will be low in our ACTH-independent Cushing syndromes. This includes adrenal Cushing's, which usually involves a cortisol-secreting tumor right there in the adrenal. All that cortisol inhibits ACTH production through negative feedback. So high cortisol, low ACTH? Get imaging of those adrenals and look for a mass. That is, after you've ruled out exogenous corticosteroid use, which also leads to low ACTH levels. Again, all those steroids exert negative feedback on the hypothalamus and pituitary, thereby decreasing ACTH production. In cases of high ACTH, the source could be a tumor of the pituitary gland, or some ectopic tumor secreting ACTH. For a little help differentiating these terms, we can perform a dexamethasone suppression test. Dexamethasone is a potent glucocorticoid, and in this scene, it's embodied by the dexamethasone moonstone index. To perform the test, we first do a low dose and then a high dose. This guy crouching in the corner here, collecting a few small moonstones, represents low-dose dexamethasone. This is a potent steroid we're dealing with here, so expect it to exert some major negative feedback onto the hypothalamus and pituitary, which should, in theory, decrease ACTH and cortisol levels. And this is true in cases of physiologic hypercortisolism. By physiologic, I mean times when ACTH and cortisol are naturally high due to chronic stress conditions, such as infection, surgery, malnutrition, anorexia, pregnancy, and poorly controlled diabetes. Sad, stressful times. I mean, not pregnancy, I guess. Congratulations and all. All right, so we've successfully suppressed physiologic cortisol levels. Whoop-de-doo. Both a pituitary ACTH secreting tumor and an ectopic ACTH secreting tumor will not be suppressed by low-dose dexamethasone, however. Time to turn it up to 11. High-dose dexamethasone will, in fact, suppress ACTH from a pituitary adenoma.
Glowy, glowy moonstones, moonstone time for me.
You see, pituitary adenomas are only relatively resistant to negative feedback inhibition by glucocorticoids. You just gotta beat it into submission. Time to get an MRI of that pituitary and look for a mass. Ectopic ACTH-producing tumors, on the other hand, aren't really a part of the whole hypothalamus-pituitary-adrenal axis, and therefore don't really follow the rules of negative feedback.
Glowy, glowy moonstones, moonstone time for... No! For me?
Ectopic ACTH-secreting tumors will not be suppressed with high-dose dexamethasone, so ACTH and cortisol levels persist. Time to look for that tumor. All right, quick recap. High cortisol levels can be a physiologically normal response to some underlying stress, but with a low dose of dexamethasone, cortisol and ACTH will be suppressed. Adrenal Cushing's, which involves a cortisol-secreting tumor of the adrenal, is characterized by low ACTH and high cortisol. A low dose of dexamethasone will not suppress cortisol production in this case. Both ACTH and cortisol levels are high in ectopic ACTH-secreting tumors and ACTH-secreting pituitary adenomas. So to distinguish between the two, perform a high-dose dexamethasone suppression test, which will suppress ACTH production in pituitary adenomas, but not in cases of ectopic ACTH syndrome. Next, treatment, which in the case of some kind of endogenous cause of Cushing's syndrome, typically involves surgery to remove the tumor, hence the scalpel flag there. If small cell lung cancer is the culprit, by the way, the treatment is chemotherapy. Those cells are just too dang small. Just kidding. But seriously, no surgery for these guys. Oh man, moon frickin' stones, son. Gotta clear out that pack. There are some cases in which medications are used to manage hypercortisolism. For example, ketoconazole, metyrapone, and mitotane work by inhibiting adrenal hormone production. Ketoconazole is that pinecone key. Remember that it's also used as an antifungal drug and can cause hepatotoxicity. Mifepristone, symbolized by the wiffle ball, antagonizes both cortisol and progesterone receptors. While it can be used to treat hypercortisolism, it's more commonly used for termination of pregnancy by stimulating uterine contraction. Metyrapone is represented by the makeup case. It inhibits 11-hydroxylase, a key enzyme in the cortisol pathway. And last we heard about metyrapone, it was being used as a test to prove that endocrine hypofunction was coming from the pituitary. And mitotane? Well, it's embodied by that mitosis symbol on his suit. And it directly suppresses the adrenals. Rarely, bilateral adrenalectomy is performed. And the patient must be given lifelong glucocorticoid and mineralocorticoid replacement therapy. In patients with a pituitary tumor as the initial culprit, however, a word of caution. When you do the old double dip and take out both the adrenals, a potential consequence is Nelson syndrome, represented by Nelson here, the astronaut that was accidentally left behind on the last mission, and has been subsisting off Dippin' Dots in the moon base for 5 years in isolation. You see, when the adrenals are removed, the sudden drop in cortisol causes the pituitary to freak out, at which point it multiplies its hormone-producing cells and ramps up ACTH secretion. This can actually make the adenoma get even bigger. That backfired. Pressure in the cella can cause headache and visual disturbances. And since ACTH is elevated, patients can also show signs of hyperpigmentation. And that concludes our tour of the adrenal cortex. Next, we're headed back to Earth, where we'll illustrate what goes on at the center of the gland. The medulla, of course.
Where am I going? And from whence have I come? I'm but a speck. All we are is dust in the wind. Lord of light, mad Damon, show me a sign. Anything! So many dipping dots. So many dipping